Wonderful. So, for those taking surgical critical care, one of the parts that we can really do extremely well on are trauma. So it benefits us to pay a little attention to how we would answer questions related to trauma. And always remember, there are many different answers to the same question. There is the board answer, and then there's a book answer, then there is something that you may have seen done once or somebody anecdotally told you. So it's important to focus on what would be considered the standard of care. And we'll go over abdominal and pelvic trauma in pretty big detail. So in blunt abdominal trauma, remember that because of its size, the liver is probably the most commonly injured organ in blunt abdominal trauma. However, many of these injuries are small, and the reason is because the liver is attached to the abdomen by a number of the different ligaments. And when the body comes to stop in an acute traumatic event, such as a motor vehicle crash, the different tissues keep moving based on their density and their fixity. So the ligaments hold the liver in place, whereas the substance of the liver keeps moving forward, and therefore you get these lacerations. So they're not uncommon, but they're often rather of a minor degree in most cases. The spleen is also much more commonly injured, mostly because it is such a vascular organ that even a small laceration results in a significant bleed. Now, penetrating trauma, of course, depends on whether it is a stab wound or a gunshot wound. Important thing to remember is that stab wounds are low velocity wounds. The injury will be according to the trajectory of where the stab was. So if it was left upper quadrant, right upper quadrant, the location should tell you what is the organ that is likely stabbed, and it'll follow the path of the knife. Gunshot wounds, on the other hand, depend on whether it is a small, low caliber, or it is not low caliber, low velocity or high velocity. Low velocity, it's very similar to stab wounds, follows the trajectory of where the bullet has gone through. In a high velocity injury, on the other hand, as the bullet passes through the body, it results in separation of the tissue, creating a temporary cavity. And this temporary cavity causes a damage that is far beyond what the original tract was. And this temporary cavity that's created then collapses back. So if you look at the tissue by itself, it looks like it is where it should be. However, it has traveled a lot and come back to that position. So therefore, you do have a much more significant damage. With these also, it depends on where the trajectory is. Whenever you take radiographs for patients with penetrating trauma, very important to put a radiologic marker. I use a clip attached to a piece of tape that you put on every wound that you see. We cannot tell whether it's exit or entry, but you put it on every wound that you see. And in general, the number of holes plus the number of missiles in the body must be an even number. If they're not an even number, then you're missing something. So the missing something may be the bullet may have embolized. Keep that in mind. So if the bullet has embolized, and you consider that, then you have to obtain skeletal radiographs of the entire body to find that missing bullet. So number of holes plus number of missiles must be an even number. Times when this does not happen is when you have a tangential wound and you have a wound, but the missile never entered the body, or alternatively, the missile was stuck in the clothes of the person and falls off with the clothes and never really enters the body. So that is also a possibility, but embolization is something that you really need to keep in mind. With blunt trauma, it's different mechanisms. You can get compression, crushing, or more commonly shearing injury. As I mentioned, different parts of the body come to stop at a different time. Fixity and density is what determines what the injury will be. And the places where you have changes in density or changes in fixity is where you tend to see the biggest injuries occurring. So one example of this is somebody who's had a previous abdominal operation, has scar tissue, and the small intestine is tethered to different places because of the scar tissue. So when the body comes to rest suddenly, whether it be from a fall, motorcycle crash, motor vehicle crash, the scar tissue holds the bowel in place, but the small bowel keeps on sliding forward. So you get a shearing injury. When you get that shearing injury, initially the patient may not present with anything. However, subsequently, as time progresses, that area that got denuded disrupts, and then you get a delayed presentation of a small bowel injury. So this is a patient who initially would have a benign abdominal examination, who over the course of several hours would present with peritoneal signs. And when you image these patients, the characteristic thing is a CT scan which shows the presence of free fluid in the absence of any solid organ injury. The only caveat to this is that in young women of menstruating age or of reproductive age, there is the potential for having a small amount of free fluid in the pelvis, which is physiologic and comes from when the ova is released. But other than that, especially in a male, if you see free fluid and there's no solid organ injury, you have to think about a hollow viscous injury until proven otherwise. Now, penetrating trauma, as I told you, depends on whether it is low velocity or high velocity, and cavitation results in a significantly larger injury than you would expect. Other thing to keep in mind when you look at this is the location of the injury that you're looking at. So whether they describe it as an anterior abdominal injury, flank, back, or thoracoabdominal, because each of these have different approaches to their management as we will go across. Also recognize that what we visually see as the abdominal cavity from the outside is actually larger on the inside. So if you look at the lowest part of what you would think of as chest, that is actually the intrathoracic abdomen. So on the left side, that's where you have the spleen and the diaphragm. And on the right side, that's where you have the liver and the diaphragm. So you can get an injury associated with the right-sided rib fractures, maybe 9 and 10, and have an associated liver injury. And the same thing on the left can result in a splenic injury. By the same token, that's the reason why we always advise, if you're going to put in a chest tube for anybody, always put it at the nipple line or above, because if you exhale to the greatest degree possible, you can raise your diaphragm up to the level of the nipples. So if you were to place a chest tube lower than this, you have risk of entering the abdominal cavity. So chest tubes must always be placed, or pigtail catheters must always be placed above the level of the nipple in men and above the inframammary crease in women. Also recognize that the abdominal cavity extends down into the pelvis, where it is covered by the bones that make up the pelvis. So if you have significant pelvic fractures, or if you have a bullet that enters the pelvis on one side, exits the pelvis on the other side, you have to consider that there may be an associated intra-abdominal injury. With the transpelvic gunshot wound particularly, we're worried about rectal injuries. Small bowel, little squishy thing, travels all over the place, can get injured pretty much everywhere, including in the pelvis. So you could have intra-abdominal injuries even with a pelvic fracture. Now, how we manage these patients? Initially, the management follows the ATLS protocol. The ATLS protocol is physiologically based, and we always start with our primary survey looking at the ABCDEs: airway, breathing, circulation, disability, exposure, and environmental control, because that's what is physiologic. The reason why you are alive is because you're getting oxygen from the environment to the cell. How do you get that? First, it has to pass through a patent airway. If it doesn't pass through that patent airway, whether it gets to the alveoli where gas exchange takes place or not, doesn't matter. So the patent airway remains the number one thing, irrespective of the question, irrespective of the age, irrespective of the mechanism. Till you have a patent airway, the rest doesn't matter. Once you have a patent airway, then the function of breathing to get the oxygen into blood, and then the function of the heart to get that blood circulating around so that you can get the tissue to you can get the oxygen to the tissue. That's why we go the ABCs. Why do we go with the D? Because of all the tissues in your body, the neurologic tissue is the most sensitive, about 4 to 6 minutes of anoxia, and the brain is irreversibly lost. If the brain doesn't survive, the rest doesn't matter. So irrespective of the trauma question, look to see whether they're asking you to take care of things in the primary survey. In the primary survey, you fix as you find. You don't find a problem with airway and then go to see whether you have a problem with breathing. You find the problem with the airway, you fix the problem with the airway, you fix the problem with the breathing, you get circulation, you start the resuscitation, put on the monitors, and concurrently resuscitate the patient at the same time. Now, secondary survey, on the other hand, is a head-to-toe examination where you examine the patient and you look to see what all their injuries are. You catalog their injuries and then determine what exactly that you're going to do based on this head-to-toe examination. And here is where you will do the ultrasound examination, or what we call the FAST exam, focused assessment with sonography for trauma, which has now been increased to accommodate EFAST, the extended part, including the thoracic portion, looking for a pneumothorax. There used to be a saying, a finger or a tube in every orifice. So nasogastric tube, Foley catheter, and we used to do rectal exams, but we don't really do them anymore. When I was training, the rule of thumb, and you all have probably heard this, the only reason not to do a rectal exam is either you don't have fingers or a patient doesn't have a rectum. Not true anymore. We don't do it very often. The place where you will absolutely do a rectal exam is if you have a transpelvic gunshot wound, where you're looking to see, is there blood on examination? In this case, it's very important to first cleanse the patient completely, make sure that there's no external blood that you'll be carrying with your finger, putting on a fresh glove and doing an exam, because if you see blood, now that mandates performance of a rigid sigmoidoscopy, which then, if shows blood or shows an injury, then mandates further evaluation. So that rectal exam over there is very important. The second place that a rectal exam is important is if you suspect a spinal cord injury and you want to see whether there is sacral sparing. So for the sensation as well as whether they have tone. And sometimes in a patient who's obtunded and you can't tell whether they do or do not have a spinal cord injury, you do a rectal exam to look for tone. Other than that, we've really stopped doing rectal exams. Tertiary survey is done 24 hours after the initial injury. After all the dust has settled, it's a re-examination from head to toe, looking for any new external signs of injury, looking at all the radiographs to see if they account for all the external injuries that you see, and see whether the patient has any new findings or complaints at that time. Most commonly missed in the tertiary survey are vertebral column injuries, extremity fractures, and compartment syndrome. So the patient may be obtunded, unable to complain that they have pain out of proportion to their injury in their extremity, and you have been resuscitating them. The compartment gets even tighter and they cannot complain. The only thing you notice is that they're very tachycardic, they're very difficult to sedate, and you're having to increase the level of sedation. And what the truth is that you're missing a compartment syndrome. Remember, the loss of pulses is a very, very late finding. At the start of a compartment syndrome, the first thing that happens is that the pressure in the compartment exceeds the pressure in the capillaries, so there is no transfer of fluid and nutrients from the capillaries to the tissue. There's ischemia, further increases the permeability because of the inflammatory response. Pressure rises beyond the venous pressure, so veins are occluded but arteries are not. So you've still got a pulse, but venous outflow is occluded, and the compartment pressure continues to increase until ultimately the pressure rises to above that of the arterial circulation, and now you lose your pulses. So by the time the pulses are lost, the compartment syndrome has long been going on for a long time. So compartment syndromes are very, very easy to miss, especially in a patient who's obtunded or has significant head injury, is intoxicated. So in these patients, physical examination is tremendously important. When you do that, you look for any external signs of injury. You do an abdominal and flank exam. You examine the pelvis for stability, where you rock the pelvis. Now, that should only be done by one person, because whenever you move the fracture fragments, you increase bleeding from the fracture fragments. So you don't want everybody on the team doing this pelvic exam. One person does it, and that's about it. You must always do a perineal and rectal exam looking for blood at the meatus. This is especially true with pelvic fractures. The sign of a urethral injury is blood at the meatus. If you see blood at the meatus, you will not insert a Foley. Instead of that, you will get a retrograde urethrogram, and we'll talk about that later. You also do